A very good evening. My name is Dr. Kamal. I'm medical lead from Ajanta Pharma. On behalf of Ajanta Pharma, I welcome all of the expert panelist speakers and esteemed delegates for today's Cardio Master Workshop. So it's a series of 8 sessions, and today's sixth session. Today's speaker is Dr. Bidyut Roy, who is a DM third year at SSKM Kolkata. He'll be speaking on valvular heart disease, and his session will be followed by a keynote lecture by Professor Rabin Chakraborty on valvular heart disease. Our expert panelist for today's meeting is Professor Saibal Mukherjee, Professor Ajay Mahajan, and Professor Ajay Bahl. So on behalf of Ajanta, I would like to salute all of the doctors. Ajanta Pharma salutes all of the doctors who have been true warriors in the current pandemic battle. A very big thank you to all of the doctors for fighting this battle for us, sir. And as a bit from Ajanta Pharma towards contribution of 30,000 square feet COVID center with ICU facilities. The governor of Maharashtra has appreciated Ajanta Pharma, and we also committed 6 crore rupees to fight COVID-19 pandemic in 2020. So Ajanta Pharma is committed to serve health care needs worldwide. We are there in market since 1973, and we have introduced more than 150 products which are first to market in India in last 10 years. And Ajanta is spread across 4 continents with its presence in 30 plus countries, and we are 6,500 plus strong Ajantites for a dedicated team from 28 different nationalities. We have 8 state-of-art manufacturing facilities in India and Mauritius, and also we have 2 US FDA approved units in India. So with our strong thrust on R&D, we have more than 750 scientists working across state-of-art facilities with complete value chain. And we have our strong presence in cardiology and diabetology. We have our presence in ophthalmology, dermatology, and pain management. And I would welcome today's moderator, Professor S.C. Mandal. Dr. Mandal is head of department of IPGIMER and SSKM hospital. And he has been examiner of DM and DNB cardiology, has been principal investigator of many trials. And Dr. Mandal has published approximate 50 papers across national and international journals. And he has also published chapters in many books and has been faculty and speaker both in national and international conferences. So our expert panelist, Professor Rabin Chakraborty, is from Medica Super Specialty Hospital, Kolkata. Professor Saibal Mukherjee is associated with GB Pant Hospital, Delhi. Professor Ajay Mahajan from LTMC, Mumbai, and Professor Ajay Bahl from PGIMER, Chandigarh. So once again, on behalf of Ajanta and on behalf of delegates, I extend my warm welcome to all of the expert panelists. And with this, without wasting much time, I would invite Dr. Mandal to kindly kickstart the meeting, please. Dr. Mandal, sir, please, sir.
Good evening. Welcome to all my DNB and DM PGTs all over India. It is my pleasure to, in fact, to inform you that we have got the same panelist, and with request that they have started again valvular heart disease session 2. And I think because it is a very interesting session, I will request Bidyut to start without spending any much, without wasting any time. Bidyut, please.
Good evening, respected teachers and my dear colleagues. Today I will present my Am I audible, sir? Am I audible, sir? Good evening,
yes, you are.
Today I will present my case. My patient is Mr. Idris Gazi, 55 years male, Muslim by religion, admitted in cardiology ward, resident of Shibpur, Howrah, and shopkeeper of occupations. He admitted 17 of May and examined today. He admitted with chief complaint of shortness of breath for last 7 years and palpitation for last 3 years. History of patient illness. Patient was apparently well before 7 years, and 7 years back, patient developed insidious onset breathlessness. Initially, he felt breathlessness after walking around 500 meters at his normal pace and climbing up to 2 flights of stairs, suggestive of NOH class 2. And it was gradually progressive, and for last 1 year, patient felt breathlessness even doing his ordinary household activities like dressing, undressing, and taking bath, suggestive of NOH class 3. Breathlessness was relieved by taking rest. And in the last 1 year, there is a history of recurrent episode of the nocturnal happening due to the breathlessness. It typically occurs 2 to 3 hours after sleep. He had to wake up for shortness of breath, and he used to get relieved after sitting upright posture with dangling his leg by the side of the bed. Breathlessness is not associated with cough and with expectoration or any seasonal variation. There is also a history of palpitation for last 3 years, which are gradual onset, regular pulsation type, pounding type sensation in the chest, present in left lateral position in more cases, and increasing during activity with no history of sudden increase or decrease or changing in the character of the palpitation. It is not associated with polyuria, initially occurred intermittently, are now occurring persistently, which with mild exertions. But during the last 1 month ago, patient developed sudden onset palpitation, which is beating wings type with irregular type and associated with polyuria, terminates spontaneously. And it is associated with shortness of breath, which increases in severity from before and patient become restless on lying down position, and patient, it reduced on upright position and after taking medication. He also complained of dyspnea on bending forearm during this time. And following this episode, patient also developed bilateral lower limb swelling, which disappeared after taking medication for about 7 days. And for last 1 month, patient also complained of easy fatigability.
So,
Negativity. Yes.
Ek minute. Okay. Just let's analyze your history first. So what was he? He is 55 years old, right?
Yes, sir.
And his symptoms have started from the age of 48 years, as per your history. Okay.
Yes,
till 48 years, he was totally asymptomatic, and it started with dyspnea.
Yes, sir.
Just go back to your slide. And yeah, next one. So what was his the previous one. So what was his NYHA class? What do you mean to say? What is class 2 and what is class 3?
NYHA class 2 means patient with cardiac disease. Ordinary activity causes symptoms, and normal physical activity.
So you have written he used to become breathless while carrying on his ordinary household activities. So is he class 2 or class 3?
During ordinary activity like dressing and dressing, it is class 3.
If it is less than ordinary physical activity, it is class 3. See, these things you cannot confuse at all. This is, if you're right at the start of your history, if you mess up with your NYHA class, it carries a very poor impression. Okay. And it is you who is saying, you are putting forward your diagnosis. So if he is ordinary physical activities, he cannot do, he is symptomatic. And if it is less than ordinary physical activities, is 3, right?
Yes, sir.
So here is one thing I wanted to point out. And next you said is recurrent episodes of PND. You meant to say PND.
Yes, sir.
And how does this PND get relieved? He say
PND,
used to get up
and sitting upright posture with legs by the side of the bed.
That usually used to cause the relief associated with any cough, sputum.
No, there is no history of cough or expectation of sputum during this time, sir.
Just sitting and up and in upright position used to relieve his breathlessness.
Yes, sir.
Why is it not an episode of nocturnal asthma? How would you differentiate nocturnal asthma from this episode? You are attributing it to be a PND, I suppose.
Yes, sir. Nocturnal asthma, sir, particularly happen during the early morning. And there is a history of seasonal variation of breathlessness, and there is a history of intake of inhaler medications or family history of.
How do you differentiate asthma usually from a PND?
This PND and nocturnal edema, this was asking by sir. PND and nocturnal edema.
PNDs typically occur after 2 to 3 hours of going beds, and patient during this time patient feel breathlessness, and patient sits wake up from sleeps and goes towards the window to get fresh air, and by sitting or by hand by leg side by the body or without it passes for 10 to 15 hours. Sometimes it may be associated cough with expectation of being put up.
Now, nocturnal asthma is also associated with because of accumulation of secretions. It also may occur in the night. You know, that similar sudden onset of breathlessness just after they sleep. How to differentiate the nocturnal asthma and PND?
Nocturnal asthma patient, there is family history of asthma or any allergic disorder, and there is seasonal variations, and it particularly occur early in the morning.
Now, is usually relieved by a lot of expectoration and by inhaler.
Inhaler, yes, sir.
Next, go to your next part of the history.
Yes, sir.
So for this palpitation, what you need to say is it was a volume overloaded condition, yes, where he was aware of his increasing heartbeat and last 3 years. And next, now for the next, go to the next one.
And for the 1 month ago, patient developed one palpitation.
What do you mean by this beating wing type? What is this description?
It may be due to arrhythmic type of palpitation, sir.
So beating wing type, what is this? What do you specifically want to say by this term, beating wing type?
And this means this is sudden onset and rapid and irregular activity, and maybe due to sudden onset atrial fibrillation during this time, sir. And
you have written it used to terminate spontaneously.
Patient says it terminates spontaneously, and after that there is increased.
And what was an onset also spontaneous or related to some activity? That
onset also has spontaneous, sir.
Spontaneous in onset, spontaneous in offset.
Offset. And it is followed by increase in severity of shortness of breath.
You have written taking medication. What medication used to relieve this palpitation?
Palpitation was spontaneously terminated, but breathlessness relieved on taking some patients tablet like diuretics. That's it.
Diuretics cannot relieve palpitation, no?
No, palpitations are relieved spontaneously.
You have written, I see whatever you write, you have to be very clear and perfect. You cannot write like this, then these types of questions will come up. You yourself have written after taking medication. What type of palpitation? Is it a paroxysmal A for he's taking some oral pills which is getting? So all these questions will come. So don't invite trouble by writing such things non-specifically, number one. If you have to mention, you say sometimes he had a sudden onset of palpitation, irregular in types, subsiding spontaneously. Well, we can think of some superimposed arrhythmia, but don't mix up the things. If you write these things, you will be in trouble and you have to answer these questions. You understand? So you cannot say diuretic is relieving palpitation, right? After this episode means there were frequent episodes of this self-limiting palpitations, which was followed by development of features of systemic congestion.
Yes,
that is what you want to say.
Yes, sir.
Okay. Go to your next one. So these are the positive things in history.
Yes, sir.
So important negative points.
There is no history of fever associated with period of worsening of the symptoms, no history of syncope, loss of consciousness, no history of chest pain, intermittent claudication or unilateral limb weakness, no history of productive cough, hemoptysis or seasonal variation of the shortness of the breath.
Continue.
Yes, sir. Past history patient give history suggestive of acute rheumatic fever when he was about 10 years of age. During this episode, patient developed fever, which is followed by a joint pain, predominantly involving the large joint, which is migratory, associated with swelling and redness, and this is lasted around 2 weeks. After which, patient gave a 3-weekly injection, which he took for about 6 months, and he stopped because he was feeling better as per his statement. And there is no history of diabetes mellitus, hypertension, thyroid disorder, no history of any hospitalization, or no history of pulmonary TB or known early liver kidney disease or chronic illness.
You've mentioned one history, that history of breathlessness on bending forward.
Yes, sir.
What does that mean?
That is means the patient is suffering from bendopnea.
Bendopnea. So what is the
Yes.
diagnosis of bendopnea? What are the conditions where you get bendopnea?
Bendopnea particularly happen in heart failure, in weight and dry variant type.
Sorry, heart failure and?
In heart failure, advanced stage of heart failure, in weight and cold type of heart failure. So, increase LV and filling pressure and decrease cardiac index.
Okay.
No, bendopnea.
What are the other conditions? Apart from heart failure, what are the other conditions where you get bendopnea?
Apart from heart failure, we can in valvular heart disease in advanced stage of.
So that is heart failure due to whatever cause. It has to be advanced heart failure, not in early heart failure.
Advanced heart failure, yes, sir.
Yes. So what else? What are the other conditions where you get? There's no advanced heart failure yet bendopnea is present.
I can get it inside massive ascites or pregnancy and COPD patient.
COPD, yes.
Much more common, yes. COPD, yes. Anything else?
COPD is a common cause of bendopnea, and the other is hypertrophic cardiomyopathy also.
Yes,
what is the mechanism of bendopnea?
Mechanism bendopnea occurs due to the increased LV filling pressure.
Yeah,
and
LVDP, correct. That is right. Continue.
And patient treatment history, patient had put on multiple drugs over the last 1 year, and he this time claimed to be compliant with this medication, yet he became symptomatic, and for this reason he admitted in the hospital for further management. And personal history, patient started up to class 4 and married, shopkeeper by profession, mixed diet, no history of smoking, alcohol effect, no history of exposure to any sexual transmitted disease, bile, bladder, appetite, sleep is normal. Family history and socioeconomic history, patient lives with his wife, 2 sons, 2 daughters. Patient lives in pack house, but overcrowding is present. No history of any heart disease or sudden cardiac death in the family. This is summary from history. 55 years male, shopkeeper, non-diabetic, non-hypertensive, with past history suggestive of acute rheumatic fever at the age of 10 years, with non-compliance of IM3 Ugly injection, presented with complaint of shortness of breath for 7 years, palpitation for 3 years, which increases in severity for last 1 year, with worsening of symptom 1 month ago after changes of the palpitation type, with associated breathlessness on lying down position, and history of EG fatigability during this last 1 month, and symptoms increases from previous in spite of medication. For this patient admitted in the hospital for further management.
So what is your conclusion? How do you conclude? What do you make out from the history?
From this makeout, I can say that this can be a valvular heart disease, as there is any history of rheumatic fever, probably due to rheumatic origin, with mitral stenosis and regurgitation lesion like mitral regurgitation and aortic regurgitation, or bicuspid aortic valve with degenerative.
No. So no, I think when you summarize, you should first define what all he has.
Okay.
He's got left heart failure.
Yes, sir.
He's got volume overload palpitations.
Yes, sir.
Then after that, he has developed right heart failure.
Yes, sir.
Then he has developed irregular palpitations, isn't
Yes,
it?
sir.
So that is the pattern. So he's got a disease predominantly. So you have to explain each one of these: left heart failure, volume overload, then irregular palpitations. Now, why do you think? See, he had rheumatic fever at the age of 10 years, right?
Yes, sir.
And he became symptomatic at the age of 48, 40, 47 or 48 years. So why do you think he became symptomatic at the age of 47? Recent worsening of symptoms, we know that he had irregular palpitation, maybe he developed AF. So why did he become symptomatic at the age of 47 years?
Okay, sir. Patient after the age of at the age of 10 years, when patient diagnosed to have a rheumatic fever, and he was subscribed seriously prophylaxis, secondary prophylaxis for rheumatic heart disease, but patient does not take it. For this reason,
so do you think that
so you he did, sorry, he didn't get rheumatic fever at prophylaxis from the age of 10 years till 47 years, isn't it?
Yes, sir.
So why? So you think at the age of 47 years he developed rheumatic fever?
No, sir.
That is the cause of his worsening. Why did he worsen at 47?
Worsening maybe due to, sir, one is, sir, due to, sir, subclinical, sir, arrhythmia or subclinical carditis, which can
no, rheumatic carditis causes heart failure. You think he had rheumatic carditis at age 47 years?
No, sir.
He became symptomatic only at the age of 47 years, no? Before
Yes,
that, he was asymptomatic as per your history. So a patient with rheumatic heart disease, what is the usual age when they become symptomatic? You have seen so many patients of mitral valve disease, mitral stenosis coming to your OPDs.
Sir.
What is the usual age of presentation?
Second to third decade, sir.
Yeah. So if it is, it's second to third decade usually. And here your patient is in the fifth decade actually.
Yes, sir.
And he only became symptomatic only in the fifth decade. So sir is asking, what would be the other probabilities you would keep in mind?
It can be, sir, bicuspid aortic valve can be.
No, you're talking about rheumatic heart disease. Don't bring in another etiology.
You talk of rheumatic heart disease. In which condition, how can this be possible?
Go through it systematically. They're very basic things. Why does a patient with RHD become symptomatic? One is rheumatic fever, which is very unlikely. For 37 years, no rheumatic fever, then suddenly at age of 47, acute rheumatic fever. That is not there. So what are the other causes by which he could have become symptomatic?
Maybe, sir, associated coronary artery disease at this time.
Okay, one associated coronary artery disease. What else?
Or maybe, sir.
There's no angina, no history of angina, so that is less likely. What else?
Yes, sir. Or maybe, sir, precipitation by infective endocarditis or incidence
there is no 7 years he would not have survived without treatment.
Yes, sir. Or
can the valvular disease progress even in the absence of rheumatic activity?
Yes, sir.
What happens to what are MR? Don't you say MR begets MR?
Yes, sir.
Isn't it? Then the valve is undergoing hemodynamic stress.
Wow. What is the mechanism of progressive damage? Last day, sir ne ye bataya tha. There were mechanisms of progressive damage to the valves. Is it? What are the mechanisms described?
Yes, sir. In case of acute MR, mild cases.
Acute nahi. Ye patient ke baare mein baat kar rahe. Eta we are talking about this patient only. Suppose he is rheumatic heart disease, and what are the possible factors which leads to progression of the valvular disease?
What are the hemodynamic factors which progresses? Valve disease progresses.
One thing, sir, can be severe attack at the time of the first episode, repeated infections, lack of prophylaxis, carditis at the age of young age, and poor socioeconomic status.
No, Vidut, don't waver around. There are 2-3 definite reasons. Valvulitis. How does this valvulitis, if there are recurrent attacks of carditis, that is one of the cause of progressive valvulitis or progressive damage. Apart from that, what other causes can produce progressive valvular dysfunction? That is the question. Sir ne question me answer bata diya. Bole diye cha tumhe. I mean, already given you the answer in his question only. So whenever a valve is abnormal, what happens? What happens?
It causes increased shear stress on this valve, and which causes more damage, and which causes more readdition and more shear damage.
Hemodynamics, very simple.
Hemodynamic stress on the valve, okay?
Yes, sir.
Either a stenotic lesion or a regurgitation lesion,
yes.
The flow is always abnormal. And
yes,
this progressive disruption of the hemodynamics leads to
further damage and
progressive valvular damage. Yeah.
Yes,
so this is the basic mechanism.
What are the other causes by which he could have become symptomatic? So one is progressive valvular damage. Then what else? Anything else that you can think of?
In this patient?
Or maybe, sir, any volume overload or pressure overload condition like anemia, thyrotoxicosis patient develop, or uncontrolled hypertension.
LV dysfunction?
Yes, sir. Can be developed.
If he has a regurgitant lesion over a long time, LV dysfunction can set in, and that can
yes, sir.
cause.
So what? So first differential, you want to say keep as?
Sir, valvular heart disease as there is history of rheumatic fever, so probably maybe due to a rheumatic origin with mitral stenosis and regurgitation, like mitral regurgitation and aortic regurgitation.
Which one you want to give? Mitral stenosis with concomitant regurgitation or mitral stenosis with aortic regurgitation?
So I like to keep mitral stenosis with aortic regurgitation first, then mitral regurgitation.
Mitral stenosis, why do you want to keep mitral stenosis?
Because there is a long-term history of shortness of breath, 7 years, and patient develop history of increased left due to LA pressure, increased pulmonary capillary UH pressure due to the increased LA pressure, due to the mitral inflow obstruction. So I will keep mitral stenosis.
And regurgitation across the aortic valve?
Yes.
Or mitral valve?
Or mitral valve, yes.
No, I'm asking you.
When
you want to keep?
First will I'll keep across the aortic valve, aortic regurgitation.
Why do you say aortic valve? Why not mitral valve? There's nothing specific. See, he does not have neck pulsations. If he had neck pulsations, you could have said aortic valve. If there was nocturnal angina, you could have said aortic valve. But here there are no features for either aortic or mitral, so you should keep both in mind.
Both in case.
Yeah, absolutely.
You said pounding pulsation. Usually mitral regurgitation will not get pounding type of pulsation.
Pounding pulsation, and in case of
you said pounding, then you can go for aortic.
He said pounding. That's why I'm asking.
Then you go for aortic.
Yeah. And you have kept as a cardiomyopathy. What cardiomyopathy do you think?
First, sir, I will keep, sir, as there is long-term history, first I will keep hypertrophic cardiomyopathy, then dilated cardiomyopathy.
No, hypertrophic should not have volume overload. He has volume overload palpitation, so that should not occur in.
And in case of HCM, sir, there is 10 to 20% chance of aortic regurgitation. That can be less preferable, sir.
Can it be RSOV?
RSOV, sir, there is acute history and there is stress factor, so I will not keep it as first.
Sorry, acute history and
there is history of stress and there is acute presentation, so I will not keep it as first choice.
No, differential diagnosis, can you put as RSOV?
No, sir.
Why? What is the natural history of RSOV?
It particularly, sir, happen in case of young people with history of stress and sudden onset chest pain and palpitation, and duration will be such short and acute presentation. There will be no chronic.
Presentation can be acute. There is also a subacute variety where there can be. But what is the natural history? Whenever you keep any diagnosis, you must know about the natural history of the diseases, which will be varying and very important when you keep a differential. 7 years history of dyspnea, right? And followed later by features of right-sided failure. Does it go with the diagnosis of RSOV? This way you have to actually differentiate and break down your differentials. You have written
volume overload condition, so you must know the natural history of the volume overload condition.
Yes.
Which one will you exclude? Which one will you keep?
Don't write coronary artery disease. What do you mean by coronary artery disease? In your differential, you have kept as coronary artery disease.
You've kept MI, chronic stable angina. What is this?
What
my would say ischemic cardiomyopathy with the coronary artery disease with ischemic cardiomyopathy.
Should say that.
So you write that coronary artery disease doesn't mean anything. It is such a wide spectrum. You have not mentioned anything. Don't write like this in your exam. And what about CTGA? Why did you keep a probability of CTGA?
In case of simple CCTGA, patient can present with RV failure with valvular ejection at around 4 to 5 decades of life. Simply CCTGA, sir.
So the RV is the systemic ventricle, right?
Yes, sir.
And if it fails, you will get
just RV failure and valvular ejection.
Pulmonary congestion. So I think that should come higher up in your DD rather than coming down in your DD. When you have to try to involve a valve, you should bring it up. Okay, go to your examination findings.
Yes.
Tell us the general physical findings, important points. Don't need to go through all of them.
Okay.
Important findings on general physical examination.
Okay, in important findings is that pulse is 78 per minute, irregular, normal volume, no radio and radiofemoral delay. Pulse deficit is 14 and condition of arterial wall is normal and all peripheral pulse is palpable. And blood pressure in upper limb 90 by 58 and lower limb 110 by 58. And JVP is raised 5 centimeter above the standard angle at 40 degree with absent AF and prominent VF and sharp wave descent and abdominal jugular reflex is present.
Tell me, when you are seeing the jugular, why?
If the JVP is raised.
Already JVP is raised, why do you talk about abdominal jugular reflux? When do you do it actually?
And in case of, yes, in case of incipient failure or sub TR, yes.
Like you have treated a patient with diuretics, you may not find the raised JVP, or but you are suspecting. Then you do this maneuver to see how the jugular venous pressure is behaving with a constant pressure.
Yes, sir. Yes, sir.
So you don't talk about abdominal jugular reflux when you have raised JVP already. Hmm?
Yes.
What was happening to his JVP when he was sitting? Sorry, sir. What was happening when he was sitting? You said at 45 degree. Why did you? How do you look at the JVP usually? How do you start?
Yes, sir. I stand on the right side and by placing a torch light across the internal jugular veins and correspond with the left-sided carotid pulse. I see past venous pulsation columns and next the wave.
Which position do you start? In sitting or lying? That is what is my question.
How we see the JVP with those?
That's 30 to 45 degree angle, sir.
Always 45 degree angle?
No, sir. 30 to 45. In case of March range, always first sitting position. And in case of low, then lying down position.
So how do you start? You start with a sitting position,
sitting position, yes, sir.
If you are seeing a column already in sitting position, you don't make him to lie 45. Angle. It will go beyond his ears, no?
Yes, sir.
Or so if you are not seeing in sitting position, then you make them bring down the positions actually. And you said you...
What are the causes of prominent V wave in the JVP?
Prominent V waves are in JVP are presence of tricuspid regurgitation, ASD or jar body phenomena, sir.
Sorry, what is yes, okay.
Or sir, or any volume condition in
name a condition, don't be non-specific, just name.
One is sir tricuspid regurgitation, one is sir ASD, one is jar body, sir.
What else? What are the causes of prominent sharp wide descent in JVP?
Sharp wide descent is tricuspid regurgitation, constrictive pericarditis.
One is tricuspid regurgitation. What else?
One is constrictive pericarditis.
What happens in constrictive pericarditis?
The prominent X and Y descent and up.
What happens? What about restrictive cardiomyopathy?
Restrictive cardiomyopathy, there is also, sir, sharp OI descent, sir, X and Y descent.
So if the JVP is raised at baseline, there's no need to look for abdominal jugular reflux. No.
Yes, sir.
If you don't get a raised JVP, then you look for abdominal jugular reflux. So with your blood pressure, is it more compatible with MR or AR?
More compatible, sir, mitral registration, sir, with LV dysfunction.
But you got a Hill sign of 20.
20, yes, sir.
Okay, continue.
Yes, sir. And cardiovascular registration peripheral signs of aortic registration absent. On inspection, chest is normal.
Sorry, go back to the last.
Okay.
What are the causes of irregular pulse?
One is atrial fibrillation, and another is multifocal atrial tachycardia with variable ventricular rate.
Two, multifocal atrial tachycardia. What else?
And atrial fibrillation.
What else?
Or sir, atrial flutter with variable block, or maybe, sir, it may be, sir, ventricular fibrillation.
Fibrillation.
Will you get a pulse?
No, sir, no, sir.
Then what will be if there is multifocal atrial? Can be multifocal VPCs also.
Multifocal VPC, yes, sir.
So if you get very frequent ectopics, some atrial, some ventricular, multifocal, again you'll get an impression of an irregular pulse. Ventricular fibrillation, you won't get any pulse, isn't it? Okay, continue.
On inspection, chest is a normal size with bilateral symmetry without any obvious bulge, retraction, and scar mark. Visible apical impulse in 6 intercostal phase, lateral to the midclavicular line. No epigastric pulsation, no venous distension, any discharging sinus. On palpation, apex suite is left 6 intercostal phase, half-inch lateral to the midclavicular line. Not, sir, forceful to weak and slightly prolonged and LV type.
No, I don't think there is a term like less forceful.
Sir,
No.
actually, sir, I could not appreciate it properly. It was between weak and forceful types, sir.
It's varying, no, because you have an atrial fibrillation. So your character cannot remain the same, no? It will vary with your degree of filling of the ventricle. Is it a LV type? Is it a localized apex?
Yes, sir. Localized type is LV type, sir.
Okay. So what do you see? There is apparently a cardiomegaly. The apex is shifted outside. And a localized LV type of apex. That's yes, what you can comment. Then?
So palpable P2 is present in the left second intercostal phase. No palpable third and fourth heart sounds. Left pasternal impulse present, grade 2. Epigastric pulsation present, and no palpable click or pericardial or not present.
I don't think you should say P2. You should say palpable second heart sound. You can't be sure whether it is A2 or P2 on palpation. It could be both. So just say second heart sound. Okay, continue.
Liver dullness present is a right fifth intercostal phase, midclavicular line. Left heart border corresponds to the apex, and right heart border is 1 centimeter from right sternal border. On auscultation, sir, S1 is variable intensity, predominantly loud. S2, aortic sound is soft and loud. P2, normal physical speed. S3 is present. S4 is absent. Openings are present, but I cannot interpret it, sir, O2S interval.
But you got S3, and you are telling opening snap present, you could not find out A2OS. Is it S3 or opening snap?
And it was, sir, both was present, sir, opening snap S3.
What is your degree of severity of mitral? How can you expect an S3 in presence of a significant stenotic lesion across the mitral valve?
And in case of mitral stenosis, it is rare to present S3, patient from the patient history, there is also presence of
History nahi. Your auscultatory findings, is it going hand in hand? You are saying a loud variable S1, you are having a loud P2 because of PAH, and you have a JVP raised, right-sided failure, and you are saying you have an S3, LVS3.
Yes, sir.
So what is the genesis of S3?
S3 maybe, sir, due to the left ventricular dysfunction, sir. Left ventricular systolic dysfunction or presence of.
What is the mechanism of production of S3?
Yes, sir. There is three theories, sir: valvular theory, ventricular theory, and impact theory, sir. During regurgitation jet causes vibration in the valve, which causes S3, or during early rapid filling, which causes deceleration of the left ventricular muscle mass, that causes a sound, which is S3, or during early filling, cardiac wall impact with the chest wall, which can also cause S3.
Left-sided S3.
Yes, sir.
Is S3 possible in presence of significant MS?
No, sir. In case of significant MS, it is not.
Not possible.
Possible if there is associated LV dysfunction or others valvular lesion is present.
It's very difficult to find a S3. You know, you can palpate a S3. Auscultation is very difficult because it's in the middle of the murmur. No, first is your opening snap. The moment you have your opening snap, your murmur starts. So the S3 is in the middle of the murmur. To appreciate an S3 is not easy if there is a MDM. Isn't it?
Yes.
It's overlapping the murmur.
Yes.
If you palpate a S3, fine.
If you get palpable SC, okay, but auscultation very difficult. And patients with MS, LV dysfunction with air, you may get SC because feeling occurs from the aortic regurgitation.
Aortic regurgitation and
feeling occurs from the aortic regurgitation, and if there is LV dysfunction, even in spite of severe MS, LV dysfunction in air,
yes, you can get an S3.
But SC will be palpable, most important.
S3 is more often palpable than audible. You know? So S1, S2, S3, acha, sounds, these are the sounds you had.
Yes,
what did you say? Opening snap, A2 opening snap could not be interpreted, matlab?
I cannot interpret the intervals. There is
A2 opening snap interval, you cannot, it must be varying, no?
Yes, sir.
So what happens to the interval in dynamic auscultation? After a long cycle length, what will happen to the A2OS interval? And after a short cycle length, what will happen to the A2OS interval?
After a short cycle length, O2S interval will be decreased, and after a long cycle, it will be increased.
Oh, good. Oh, go to the murmurs.
And there is a on its mid diastolic rumbling murmur with pre-systolic component just after the short cycle. There is variable intensity and base third apex in the left lateral position with veil of the stethoscope and breath held in expiration, last up to the second half of the diastole. And there is another murmur that is early to mid diastole.
So in the setting of atrial fibrillation, can you get a pre-systolic accentuation or not? Is it described?
Yes, sir, I can get some pre-systolic accentuation. Even in long cycle, I can also get that.
Oh. But it's not very common. But it's been described. It has been described.
Is it accentuation or persistence of pre-systolic murmur, Vidyut? Will you get accentuation or the persistence of the pre-systolic murmur?
Sir, actually, here is mechanism due to the not due to atrial contraction, due to the vibration of the valve.
So there is a persistent pressure gradient till the onset of systolic. So you may get the pre-systolic murmur in severe mitral stenosis, not accentuation. P-systolic component will be there.
This, before you go to your second murmur, you said early to mid diastolic. It is either early or it is mid. It cannot be both. How do you define an early diastolic murmur? How do you define a mid diastolic murmur?
Early diastolic murmur start just after the A2 and mid
No,
diastolic.
it starts with the second heart sound.
Start with the second heart.
If it is a pulmonary, it will start with P2. If it is a aortic, it will start with A2. If there is even the slightest gap between the murmur, you will call it a mid diastolic murmur, isn't it? So it either starts with the sound or it does not start with the sound.
So start with the sound, sir.
Then you should say early diastolic. You should not say mid diastolic. Right? Because you see, even in a MS murmur, if it's very severe MS, your gap S2OS interval and when your murmur starts may be very small, but it's mid diastolic because there is a gap.
What is the problem in saying early diastolic? Why you tell mid diastolic murmur in air?
You should not write that word mid diastolic murmur. You should have written only early diastolic murmur.
Yes, sir.
Continue.
Yes, sir. And it peaking early with decrescendo murmur, high pitch, flowing in character, based on with
one
diaphragm.
second. It's a decrescendo murmur. So how can a decrescendo murmur peak? Decrescendo means it's going down in intensity continuously. Where does the peak come in? Peak is only for systolic murmur.
Yes.
Decrescendo cannot peak.
Peak nahi aur duration bhi batana padega. You have to talk about the duration of the murmur.
Sir, duration is the early part of the diastole, sir. I cannot.
Duration. How much of diastole it is occupied?
Less than 50% of the diastole, sir.
Less than 50%.
Yes, sir.
Okay.
And it is based on with the diaphragm of the stethoscope and patient in sitting position and leaning forward in left third intercostal place.
So what do you make out? What is the severity of AR based on this murmur?
Based on this murmur is not severe, sir. Mild to moderate, sir.
Okay. So what are the causes of severe AR where you get the murmur is relatively short?
One is presence of LV systolic dysfunction.
Yes.
And one is presence of uncontrolled hypertension, or one is presence of proximal.
No, why will hypertension might increase the murmur if your systolic blood pressure is 200? Why will your murmur should increase?
Sorry, sir. In case of acute AR, sir. Sorry.
Acute
AR and LV.
Or in case of severe proximal stenotic lesion like mitral stenosis.
Or mitral?
In case of proximal severe stenotic lesion like severe mitral stenosis, sir.
Okay. Oh. So it may be severe AR with LV systolic dysfunction. That is also a differential diagnosis you have to keep now. Okay, continue.
There is another pansystolic murmur of grade 3/6, which is blowing high pitch, loudest at the apex, hard in left lateral position, which radiates toward the left axilla. Standing diminishes the murmur, whereas squatting augments the murmur, and no change in intensity of the murmur with the cycle length of the air.
Right. Yes, continue.
Yes, sir. There is another pansystolic high pitch grade 3/6 murmur, which is hard in left lower external area, louder with inspiration and passive leg rising.
Continue.
Yes, sir. On other system examination, respiratory system examination, there is on auscultation bivasal fine respiratory cavitation is present. On abdominal system examination, liver is palpable 3 cm below the right costal margin. Liver span is 17 cm in right midclavicular line. Soft. It is slightly tender, smooth and rounded margin, and moves with respiration. Left lobe is not enlarged and no pulsation. Upper border liver dullness is right fifth intercostal place, and no RAP. And there is no ascites, and other system examination is within normal limit.
Go to your diagnosis.
I guess maybe the valvular heart disease, rheumatic etiology with severe MS, severe AR and moderate to severe MR and probably functional TR. In atrial fibrillation with control ventricular rate, sign of PVH and sign of PH and sign of CCR in OHA class 3 and 4 and without any evidence of infective endocarditis.
No, so which of the regurgitated lesion is, you said severe MS, but the apex is down and out. So which of the lesions is severe? You said AR is severe or MR is severe?
Sir, AR is severe. MR not some moderate.
Why do you say MR is not severe? How do you assess the severity of MR in the presence of AR?
Yes, sir. To assess the severity, I have to first is history, and then there is presence of pulmonary hypertension and presence of S3.
No, but see, patient has MS. So patient has MS, pulmonary hypertension can be because of MS. So patient has a apex down and out can be because of AR as well as MR. So how do you assess severity of MR in the presence of an AR?
Sir, S2 will be, sir, widely split, sir.
Good. One. That is good. If the S2 is widely split, then you say MR is severe. What else?
And another, yes, sir. Another is presence of, sir, flow murmur across the mitral valve.
No, that is you have MS.
MS, yes, sir.
MS can be there. Flow murmur is because of MS.
And S1 will be, sir, normal to soft.
Yeah, S1 will be soft. So you have a soft S1, you might have a LVS3. Of course, that is not applicable in this patient because of the MS.
Yes, sir.
Right. Okay. So what have
atrial fibrillation? Associated atrial fibrillation will also give some clue that the mitral regurgitation is significantly more in the presence of AR.
Mitral murmur will not change with the cycle length of the AR, sir.
The presence of AR, the presence of AF.
Yes, sir. Presence of AF also suggests MR is severe.
Then murmur, severity and conduction.
In this patient, you have got S3, severe MS with severe MR or severe AR. If you get S3, AR is most important because in severe MR even, presence of severe MS will not get the S3.
Yes, sir.
In AR, because of regurgitant lesion, there will be feeling is there. So in LV dysfunction, you may get the S3.
The second thing is if you have a severe AR, at least a short ejection systolic murmur should be heard in the across the aortic valve. So you have not mentioned any ejection systolic murmur. No, that will strongly. I mean, I have rarely seen a patient with AR where a short ejection systolic murmur is not present.
Actually, sir,
that is not heard.
No, not heard.
Not heard. So another thing missing from your diagnosis when you say no evidence of infective endocarditis or rheumatic activity.
Rheumatic activity, yes, sir. Rheumatic.
Now you said NYHA class 3 to 4. Is it 3 or is it 4?
No. Will you say rheumatic activity in this age group? 54 years.
Do you need to say it or you can
yes,
assume it's not there?
Rheumatic activity can even some studies showed it can be even seen at the age of 45 to 50 years.
Yeah, but at this age, I don't think it's been
54 years.
Yes,
55 years.
Not been described at this age. So you even if you don't mention, it's okay. What about NYHA class? Either you say 3 or 4.
Sir,
why stay in between?
Sir, now it is sorry, sir. Now it is 4 class. Percentage.
But in heart failure,
heart failure percentage.
You told the percentage on WhatsApp, Nia.
Yes, sir.
Then why you make it class 3?
Sir, class 4, sir.
Can atrial fibrillation itself give rise to TR? That
yes,
means
sir,
everything valve is normal, atrial, can it give rise to TR?
Yes, sir. Atrial fibrillation can also give rise to TR.
What is the mechanism?
Due to
yes. What is It can give rise to annular dilatation and give rise to
annular dilation. Yes, sir.
just like if your RV is enlarged, like in pulmonary hypertension, you can get a TR. Even in isolated atrial fibrillation, you can get a TR because the annulus can dilate. What is the difference between an annular dilatation that you would get due to a pulmonary hypertension versus what you get in an atrial fibrillation?
In case of pulmonary hypertension, annular dilation is all over the circumferential, and in case of
not at all. Not at all. Which part is more dilated in pulmonary hypertension? Which part of the annulus? It's anterolateral, whereas in atrial fibrillation, posterior medial, that is more dilated. Okay. So you're still not committed as to what you consider severe. AR is severe or MR is severe, or both are severe?
Sir, AR is severe, sir.
But what are the features for severe AR? Give the points.
One is present history of shortness of breath and palpitation and presence of LVS3.
LVS3 would go more for MR than for AR. LVS3 you can get in MR with normal LV function. Whereas if you get
normal in presence of
LV dysfunction, AR, it is always LV dysfunction.
LV AR, yes, sir. LV
okay, so one. So what are the features why you say severe AR from your findings on examination?
Only, sir, blood pressure is, sir, lower side.
So that goes against AR. That goes against AR. In AR, you would expect that the systolic, there is systolic cutoff of blood pressure. So that goes against the severe AR. Your murmur is also short. You've got a blood pressure is also low. Your Hill sign is only 20.
One thing, sir, only due to presence of LV dysfunction and presence of S3 on this basis.
So you think there is LV dysfunction? So you
it's very difficult to differentiate your severe AR and severe AR in this patient.
When there is a S3, always you have to, in presence of mitral stenosis, always you have to think there is a mitral regurgitation is severe.
And you have got, yes, what are the, how do you assess the severity of MR?
MR, sir, first is presence of soft S1 or normal, S2 is oddly split, presence of S3, and sign of pulmonary hypertension and presence of AF.
So you have an S3, you have AF, and you have a pansystolic murmur radiating to the axilla, cardiomegaly.
So when Hill sign is only 20, when there is systolic decapitation, the aortic regurgitation is not that much severe. There is a more of mitral regurgitation because the forward flow is very less as compared to the flow which is coming to the left atrium.
There is a question in the chat box as whether opening snap is audible in patients in atrial fibrillation. Yes, the opening snap is very much audible in patients with atrial fibrillation.
And it varies, as sir had asked, varies with the duration of the cycle. Shorter cycles, higher LA pressure. So the gradient will be higher, it will be.
Right.
And you have written sign of PVH. Okay. Sign of PVH. What is the sign of PVH?
Yeah, it said JVP is raised.
No, JVP is not a sign of PVH.
JVP is not a sign of PVH. Sign of PVH will be your class 3 symptom.
Symptom of orthopnea, PND, and patient and
breathlessness.
Breathlessness is present, yes.
Yeah, okay. That's it.
And what did you have about PAH?
On patient find this of palpable sir, second heart sound. And
Which component?
P2 sir.
P2.
There is a
Yes, sir.
murmur of tricuspid
Palpitation
regurgitation.
parasternal hit grade 2 there, sir. And murmur of tricuspid regurgitation is also there.
And what
So
do you expect
with this
about
diagnosis? With this diagnosis, what investigation you want to see? First, X-ray or ECG?
I think first X-ray, sir.
Huh?
X-ray,
So what
sir.
you want to see on in X-ray to differentiate between severe AR and severe MR?
Sir. In case of sir severe MR, there will be sir LA will be hugely enlarged, and in case of severe AR, LV will be both will be LV enlarged, but in case of MR,
For LA enlargement in presence of atrial fibrillation, the X-ray will be better idea as compared to ECG. So
Yes,
we'll
sir.
see the X-ray.
Most important, you see, in MR, you will get the inconspicuous aorta.
Yes, sir.
In AR, you will
Inconspicuous.
validation of the aorta.
And here is present, sir.
By seeing the
X-ray
ascending
doesn't go
aorta,
hand in hand with your NYHA class 3 or class 4.
Yes, sir. So, pardon, sir.
This X-ray doesn't go hand in hand with NYHA
Yes,
class
sir.
4.
Yes, sir. What was treatment, and it was taken after stabilization of 10 to 15 days back.
What this X-ray suggests?
And exercises, sir, PA view, lateral view, and inspiratory plane, well penetration, situs solitus, levocardia, bony structure, and soft tissue are apparently normal. Increased
Can you keep the
cardiothoracic.
X-ray on? Sorry, can you keep the X-ray on the screen, not
Okay,
the?
sir. Okay, sir. X-ray PA and lateral view with inspiratory plane, adequate penetrations, and bony and bony structure.
is it abnormal or normal, the penetration?
Penetration is normal, sir. Because of vertebral intervertebral space are clearly seen, sir.
Clearly seen is normal or it is over penetrated?
Over penetration, sir, it will be, sir, obscure and important structure will be missed, sir.
No, the vertebral intervertebral spaces T4, T8, you can see all
We are
clearly.
seeing everything through heart also. It is over penetrated film.
It's over penetrated film.
Yes, sir.
So if a film is over penetrated, what are the problems you have?
That will answer my question.
It
will answer my question because I told you it is not going
Venous,
hand in hand
not,
with class 3, class 4.
Not match you, sir. Venous.
See, what you see, you have to speak. No, you don't say like this. It's over penetrated film, right? And then you come on, describe now what you want to say about the cardiac.
There is bony and soft situs solitus levocardia and bony and soft tissue is normal, and left atrial is enlarged and left ventricular is also enlarged, and slight upper lobe venous prominence is there and right descending pulmonary is enlarged. And
no, why do you say left ventricle is enlarged? You say there is cardiomegaly. What is the evidence of left ventricle? You are talking on the PA view or you are talking on the lateral view?
From PA view, sir, left ventricular apex border goes beyond to the diaphragm and angle is slightly obtuse, sir.
So if there is cardiomegaly of LV type, I don't think you can comment on LV enlargement, no, on a PA X-ray.
LV type.
What is the evidence of left atrial enlargement?
Sir, there is presence of double contour shadow and increase cardiac angle is increased and upward displacement of the left bronchus and oblique distance is in more than 7.
What else? Can you see the left atrial appendage?
Straightening of the left border of the heart.
Yeah, left border. You can see the left atrial appendage. Isn't it? A slight bulge on the middle. Okay.
What lateral shows? If there is any involvement of right ventricle?
No, sir. Right, there is no obliteration of the retrosternal space, so right ventricle is not enlarged, sir.
No, I don't think so. How do you define right ventricular enlargement?
One is, sir,
on a lateral view.
Yes, sir. I have to see the Hoffman regular index. I have to see that. One is obliteration of the retrosternal space.
So how do you define obliteration of retrosternal space? What is the definition? Where do you measure the retrosternal? Which point to which point?
Yeah, sir. It will be more than 5. There is some enlargement of Ajanta.
No. So what do you mean by obliteration? So you start from here, from the bottom, and where do you go up till? You go till the angle of Louis, right?
Okay.
And if our right ventricle occupies around more than 1/3 to half the retrosternal space, then you say that RV is enlarged. So here I think it's going to half the angle of Louis.
Yes, sir.
Yeah. Okay, go to the ECG.
Yes, sir. And since ECG in 12 leads with normal standardization, due to presence of absence of repetitive POF with variable RR interval, suggestive of atrial fibrillations, and in V1 and V2, presence of POF, regular POF with absence of isolated points. So there is atrial flutter is also present, and right axis deviation mean axis is around 110 to plus 110 to 120. Right ventricular block and presence of right atrial enlargement and right ventricular hypertrophy is also there, sir.
You say flutter or fibrillation?
Sir, flutter fibrillation both are present, sir.
Where is it you feel it's flutter and where you feel it's fibrillation?
In cell with V1 and V2, it's like flutter.
There is regular sawtooth appearance, no, in flutter.
Yes, sir.
There is a regular sawtooth appearance that you don't see here. So it's better to make it as fibrillation rather than committing it as flutter. Don't do both. Make it atrial fibrillation. And what is the ventricular rate?
Ventricular rates are around 90 per minute, sir.
Okay. And then then you come to the other QRS, something you see?
Yes, sir. QRS, sir, there is presence of right ventricular block, right ventricular hypertrophy, and presence of
right bundle branch block, complete, incomplete, make it. You are
complete, sir.
The DM exit exam, no?
Yes, sir. Complete right ventricular block, sir.
Complete right bundle branch block. Okay. Yes, and you didn't mention about the QRS axis?
QRS axis, mean axis, sir, plus 110 to 120, sir.
So you have a right axis.
Right axis.
You have a right axis and you have a right bundle branch block. And do you have any features of pH?
Sir, presence of, sir, right atrial enlargement is there from the presence of Q wave in the, sir.
Right, what?
Right atrial enlargement present.
Atrial enlargement in presence of atrial fibrillation is very difficult to comment, no? Anything about from the QRS morphology you can comment?
Yes, sir. Presence of a strain pattern in the, sir, V1 to V3.
The RS R' pattern is there in V1.
Talk about the R wave in V1, V2. There are two R and R prime.
Yes, R wave is more than 15. So presence of RVI, right ventricular hypertrophy, it may be indirect indication of pulmonary hypertension.
Initial Q. Hello, initial Q suggests the right atrial enlargement. There is initial Q in RVV.
Yes.
This suggests the right atrial enlargement.
And there's this R dash is also very prominent, no?
Prominent more than, sir, 15 millimeter present here. So there may be, sir, right ventricular hypertrophy and persistent of the RS pattern up to the V3. It also suggests there may be right ventricular hypertrophy in presence of RVV.
Evidence of some digoxin effect also in V2, V3.
Yes, sir. Digoxin effect is also there, sir.
The patient was in digoxin?
Patient taking digoxin during just 1 month ago, and from 1 month ago, patient continued to take digoxin, sir.
How do you differentiate effect from toxicity?
And digoxin effect is defined by, sir, short QT interval, J segment depression, or slagging ST segment, and biphasic or inverted TOF, sir.
What is effect and what is toxicity?
And this is effect, sir. And toxicity is, sir, presence of, sir, reverse sign and presence of multiple atrial
on
tachycardia
STT segment, on basis of the STT segment. STT
basis of
segment basis say the effect and toxicity differentiate. Can it be differentiated?
Yes, sir. Effect is like seen like Salvador Mustak sign, sir. Or reverse sign is presence is toxicity, sir.
Reverse correct sign is toxicity. No.
Digoxin, you will be asked about this because once we have asked you about the effect, you will be asked about the toxicities also.
If you get prolonged period, is it effect or toxicity?
It will say toxicity, sir.
No, in children only it is toxicity, in adult it is not toxicity. If you get that PAT with block, that is the toxicity. If you get multiple access test, already it is toxicity. But seeing the what Dr. Saibal told, by seeing the STT, how will you say the toxicity or effect?
Something to do with R wave, leads in which prominent R wave or.
Where you will get the effect? There is a dominance LV. Dominance LV will get the V5, V6, 1 AVL. Dominant RV will get that figure. This is the reverse tick sign, you will get the dominance of the ventricle. But if you get in other places also, that is because of toxicity. Okay, we continue.
So what does your ECG, what information do you gather from your ECG? Does it go with your diagnosis?
Not sir, fully matched, sir, with diagnosis.
What are the features which are matching?
One is sir, presence of right ventricular hypertrophy and pulmonary hypertension, and another is presence of AF, and there is no sign of any volume overload conditions.
So you are not getting very prominent LV forces, that you
Yes,
want me to say.
Yes, sir.
Maybe you have to go more laterally.
Lateral V7.
Because RV is occupying much of the precordium, no? So V8, V6, V7, V8. You had your down and out apex.
Outwards.
So that might be one of the possibilities. Okay, then.
Then, sir, echocardiogram. Sir, this is parasternal long axis view, which shows both mitral valve, its thickened and restricted movement, particularly posterior mitral deviate. LA is dilated, and there is presence of spontaneous echocontus and thrombus, and aortic valve is also thickened and calcified. And
let it move, moving Cheredam, let it run.
Yes, sir.
Yeah, tell about the aortic valve. Yeah. It is so obvious on 2D now.
Suspected, sir, oscillating mass type lesion.
No, is it coapting or non-coapting? That is the basic thing you see.
Non-coapting, sir, yes, sir.
So that is the most important thing. If you are 2D, you see the valvulets are not coapting.
Non-coapting.
So it goes in favor of a
aortic
severe lesion, severe AR.
Severe lesion, yes, sir.
Yes. See, color is like a bimbo. You don't have to put color. The most important things you must always see on 2D. See, on 2D, there is incomplete coaptation of the valvulets. Okay. And, okay.
What is the structure behind the LA? Can you see something?
Yes, sir. That is coronary sinus, sir. And
which one? Below that? What is this?
This is, sir, coronary sinus.
It's coronary sinus.
It is aorta. It is
When-
descending thoracic aorta.
Descending thoracic aorta.
Sorry,
Yes.
sir. This is coronary sinus.
Make it moving. That will be more easy. Can you keep it a continuously running loop? Yeah.
That is a coronary sinus. That is aorta, descending aorta.
Hmm. So what are you see a left atrial enlargement, right?
Yes, sir.
Then you see incomplete cupping and the mitral valve leaflets obviously it's dooming, weakened, calcification. Go to short axis.
Yes, sir. So both another view is there, sir. Another view.
Okay.
Both commissures are calcified and thickened and fused. And
lateral commissure doesn't seem to be calcified. Medial one is.
Medial is more, lateral is less calcified.
Lateral तो मुझे कुछ calcification नहीं दिख रहा. Where do you and what is your okay? Go.
And both.
Okay. Fix it. चली गया. Okay. So medial is much more calcified than the lateral.
Okay.
And so what is the area you got?
Yeah, area got, sir. I got 0.6.
0.6. Okay, go to the 4-chamber view, see the severity of regurgitation.
So I can take the color picture here.
Yeah. Freeze it now.
Yes.
When it is coming. Yeah. Yeah. That turbulent part, no? Where you have mosaic যেখানে আসছে. What is the vena contractor?
Vena contractor was, sir, 4.7, sir.
Okay. And jet area?
Jet area, sir, is around between 20 to 40% of the LA, sir.
So it's going in favor of a moderate MR.
Yes, sir.
And then what but you have to check in for what was in the and show the aortic valve now. If aortic valve can abhi disruption tha, so there is no issue. It is a significant AR. Go to the 4-chamber view. Have you seen the MR? You should check in orthogonal views. Don't comment only on one view.
Sir, I big view not there, sir. Okay.
So you have to take all the views. That is what I wanted to tell you. You have to see in the 4-chamber, in the parasternal long axis, and then see the jets, because picking up MRs in various views is very important. Sure. And your laminar flow across the tricuspid valve show the severe TR, no?
Yes, sir.
Show the jet.
Yes, sir.
No. TR.
Yes, sir. PR is, sir, mild grade. This is around, sir, 4.8. Yeah, sir. PR is a moderate grade, sir. From VC it is 4.7 and.
No. TR jet severity is not more important. What is the PA pressure from TR jet?
PA pressure is, sir. PA pressure is,
Show me the tracing of the TR jet.
Yes, sir.
TR.
Yes, sir. 37 gradient, and IBC is less.
What was, how much gradient?
37, sir.
No. This you have not picked up well. Clinically, you are getting such a murmur, JVP, PH, severe, loud P2. Do you expect this thing? How can you, suppose you are getting this jet, what maneuvers will you do to bring out the jet?
Sir, inspiration and leg rising test.
That is okay. Anything else? Can contrast echo help you?
Yes, sir.
Contracts very at times amplifies.
Amplifies, sir.
Yeah, that's a simple maneuver you can do. Then show what else are you trying to show?
And then, sir, LV dysfunction is present yet around 42%, sir. And LV is not much dilated.
So, what are the dimensions? In systolic dimension, in diastolic dimension?
In diastolic dimension is 50, and in systolic dimension is around 39, sir. 40, and ejection fraction is 42%, sir. And LA is around 52, aorta ejection 31, and aortic annulus is 15, sir, and sinus is 32, and sinotubular junction is 23, and mid ascending aorta mid level 16, sir. And D amplitude is 18, sir, and MVA is 0.64, and AVA is 1.64, pulmonary artery is 30, and mitral leaflet separation is 0.5, and anterior leaflet thickening is 0.6, and in MRZ VC is 4.3, and ERO is 11, and MV by PHT average 0.63, and mean gradient is around 10.2 average, and LVOT diameter is 2.37, and ARZ wide is more than 65% of the LVOT, and VC is 7.3, and aortic mean gradient is around 8.31, AR by PHT is around 200, and tricuspid TR gradient is around 37, and VC is around 44.7, TAPS is around 17, and tricuspid annular S prime is 10.9, and PR gradient around 20.8, and diastolic flow reversal in descending aorta, and IBC is 11.2, and less collapse less than 50% is respiration.
So what would be your management plan for this patient?
Suppose I have to, as patient age is 55 years, I have to do coronary angiography to rule out any associated coronary artery disease or not. Then, as patient age is 55, I will plan for dual valve replacement with mechanical valve, sir. And after that, medical management will continue, sir, rheumatic prophylaxis and management of heart failure.
You want to continue rheumatic prophylaxis at this age?
After, sir, valve replacement, sir. Lifelong.
Why? At the age of 55, you want to continue rheumatic prophylaxis? Are you continuing rheumatic prophylaxis? I mean, there is a lot of variation. So, till what age do you continue rheumatic prophylaxis?
In case of, sir, severe lesion with severe rheumatic arthritis with severe carditis with valve replacement up to the 40 or lifelong, sir.
Lifelong. Okay.
So the most important thing here is that you want to go for double valve replacement, mechanical valve, but also you have to think about something for this atrial fibrillation because LA size is not that much big, so you can go with the LMAs with the LA appendage ligation.
Yes, sir.
And something for the tricuspid valve?
Tricuspid valve, sir.
You mentioned the
there is
annulus. Surgeon will
Yes,
ask you for the annulus if you need to do a tricuspid annuloplasty or not.
Annular size, sir, as per ESC guideline, more than 35.
Did you measure
by
it?
3D or MRI, and by echo more than 40, sir.
So did you measure the annulus?
By measure, sir, it was 38.8, sir.
So you will plan MRI also, and then if you MRI it is more than 40, then one can think about annuloplasty.
Yes,
but the results are not that much good.
Class 2 we indicate.
So if this patient was in sinus rhythm, not in atrial fibrillation, would you have thought of bioprosthetic valves?
As there is presence of spontaneous echo contrast and LA clots, so I have to give anticoagulation. So I will preferably give him mechanical valve.
तो clot तो सब निकल जाएगा ना जब MVR करेगा gradient कम कर देगा. Atrial fibrillation है नहीं, sinus rhythm है अच्छे patient. What is the incidence of clot in patients with sinus rhythm and MS?
Yes, sir. It varies with depend upon the age. Age less than 35 years, it is at 25%, and if age more than 35 years, it is around 40 to 45%, sir.
কোথাকার data বলছো তুমি এত? Sinus rhythm, I'm asking you in sinus rhythm. LA clot.
Sorry, sir. 15% and 25%. Less than 35 years, more than 35 years.
Where did you rate this age criteria? Are you quoting from some article?
That was actually, no, sir, that was actually for AFs. I'm sorry, sir. That was not.
I'm asking you, MS in normal sinus rhythm, you have seen cases, no? Smoke, LA clot, LLA clot in patients with sinus rhythm. So what would be the incidence? It is around 5 to 15% is the reported incidence. So that if a patient is in sinus rhythm, he has a clot. Once you are removing or replacing the valve, you are decreasing the transmitral gradient. You may also ligate the LLA, and then you don't have to put them on anticoagulants, no? So if this patient is aged 55 years and he's in sinus rhythm, obviously this patient is in AF, so you will think only of a mechanical valve. Anyway, you have to give him anticoagulants. So can you also prosthetic valves? What would be the when would you consider bioprosthetic valve in this patient?
First of it, there is patient choice, sir, and if patient is pregnant patient.
No, pregnant कहाँ से 55 years में pregnant? इसी patient की बात कर रहा हूँ मैं तुमसे.
इस patient में sir, no sir.
This patient, he is there, he is in sinus rhythm. What valve will you choose? You will go for mechanical, or you will also consider a bioprosthetic?
Sir, as patient
can you consider a bioprosthetic? Can you consider a bioprosthetic at the age of 55? That is my question.
Sir, from
55, what does the guidelines say?
As per recent guidelines, sir, below 55 is mechanical. 55 to 65, we have to decision regarding risks of thrombosis plus bleeding. And after 65,
patient is 55, no? Your patient is 55. Yeah, that's why I'm asking you.
Another issue, sir, there is presence of LV dysfunction. So chances of.
How does LV dysfunction alter your choice of valves?
Presence of the LV dysfunction, there is increased chance of clot formation or thrombus formation. So I will preferably, sir, go for.
So you will not use a thrombogenic valve, no? Then it should be preferred. Bioprosthetic should be preferred. Which is more thrombogenic? Mechanical valves are more thrombogenic.
Yes, sir.
See, beyond
you have to decide two things. So one is the duration of the prosthesis, another is whether patient needs the anticoagulant.
Yes, these two factors are the key things on which you have to decide upon the bioprosthetic valves. And now the results with with our medical bioprosthetic valves, we do not have long-term data beyond 5 years. But with the surgical bioprosthetic valves, 15 years data is also available. And they have good durability.
Yes, third generation bioprosthetic valve is lifelong, after 15 years also.
Yes, so they have 15-year data. So if in between 50 to 65, sometimes you may consider even for surgical bioprosthetic valves.
So the most important thing to choose about a bioprosthetic valve in this particular patients is the annulus of the aorta. If the annulus is relatively smaller, then one should go with a mechanical valve because you may get inherent gradient and then the valve degeneration will be faster. But if the annuluses are big, then you should go with a bioprosthetic valve with same safety.
That is also very important. What is patient prosthetic mismatch?
Presence of normal functioning valve causes a gradient due to the inappropriate body size. It is more common.
Body size.
Inappropriate size.
Annulus size.
Annulus size. It is more common in female and short stature and obese patients.
So, where do you, in which if you have a small annulus size, will you, and the patient is also has an isolated aortic valve disease, 60 years old, where do you expect a larger effective orifice area, surgical bioprosthesis or TAVR, transcatheter bioprosthesis?
Sir, if annulus size is less than 80 or more than 29, I will not prefer for TAVR, sir, because in case of small annulus size, there is chance of embolization, and in case of large annular size, there is chance of annular ruptures.
I'm asking you which valves gives larger effective orifice area. You have the same valve size, surgical versus transcatheter. Effective orifice area is always larger with transcatheter valves.
Yes, sir.
And get a larger area.
Okay, already.
Okay, I think, sir, I think yes.
Yeah, the questions in chat box, I think that Ajay already answered. And there is, can we get severity of pH clinically? Definitely. You can clinically, you can say severity of pH by seeing the second P2, by seeing the leg person, hip, all the things will important.
If that P2 is,
if you get the P2 in the FX,
it is get,
that means
severe.
pulmonary artery systolic pressure is around more than 70 millimeter mercury. Even the left sternal border, it is almost 50. So all depends on then if you get parasternal hip, get 3 between the effect and severe pulmonary arterial hypertension. So you can judge clinically. Number 3 is severe AR and severe MR. Each pulse pressure reliable. Saibal?
Severe AR
and severe MR.
Severe MR.
Each pulse pressure reliable.
Pulse pressure, see these peripheral signs, sometimes you can take them, but more reliable, I think AR is what you get about the duration of the murmur. That is the most important thing in my opinion. Peripheral signs of AR will not be masked by MR, so I don't see any reason why.
It is not masked by MR. It is not masked by MR. You will get
not masked by MR. You will get it. But one thing you must remember, Hill sign is also a paradox. Yeah. Interarterially, you don't get an Hill sign. So that importance is gradually winning off actually.
I think that we answered all the questions. Now it is 8:34. So I request Dr. Rabin Chakraborty to speak on TAVI. Dr. Rabin.
Yes. I think I need to share my screen, is it?
Start your keynote address.
I think that was a wonderful clinical presentation. So I've been asked to speak on TAVR, primarily meant for postgraduate students, but TAVR, as you know, is a very big area, very big chapter, very difficult to cover in 20 minutes time. So I will probably highlight certain important points which the postgraduate doctors may find it useful for their examination purpose. As we all know, that 21st century, there are a lot of changes in the structural heart disease, and we call it a structural revolution. What has happened is a huge change in treatment of valvular heart disease, particularly aortic valve disease, even mitral valve disease. And in addition to that, so there is a field in evolution. And at the same time, we are also understanding the valvular anatomy, hemodynamics, especially with the help of newer imaging technique like 3D, CT, and even MRI. Those kind of things are helping us a lot in recognition of the anatomy and acceptance and usefulness of the anatomy for intervention. In addition to that, there are also disruptive technologies that is changing. The valve size is progressively diminishing. The delivery system like sheets and others are also decreasing. And at the same time, there's a change of guideline. So this evening, if we talk about the TAVR, let us see what exactly it is. Now, for last, I would say from 2002 onward, there are a lot of changes. Now we have rigorous clinical evaluation, at least by 7 randomized trials against the gold standard therapy of aortic stenosis. And we know that, yes, probably the catheter-based aortic valve replacement would be an option in patients with symptomatic severe aortic stenosis, especially the high surgical risk group. So in this presentation, I just quickly take you through the review of the concept of TAVR, also just salient points of evaluation of patients considered for TAVR, and some review of literature and identification of future application. As we know that people are living longer. So aortic valve disease, particularly degenerative aortic stenosis, is a result of increasing life expectancy. And this is one disease which is most frequently acquired heart valve disease. If it remains untreated, it causes significant mortality. And this is the data. If you look at the data, you can see very clearly that, that the survival after the onset of symptoms in severe aortic stenosis, 50% at 2 years and 20% at 5 years. So surgical intervention or some intervention should be performed promptly once even the minor symptoms occur. So we know today that the symptomatic aortic stenosis, if we do not treat them, the mortality progressively increases, and you've got plenty of data. This is a very age-old symptoms. We have been reading it during our DM period, and I'm sure that nowadays the present generation of students also reading the same, that with symptoms like angina, syncope, and failure, the life expectancy average survival is 2, 4, and 6 years. So that is what is probably unacceptable. And this is the natural history of severe symptomatic aortic stenosis. And the mortality of non-surgically treated patients with severe aortic stenosis in a year's time is 38%, 5 years time 68%, and in 10 years time it is 82%. So clearly we need to do something. And if you do that, then this figure can be changed to a much better one. And the severe symptomatic aortic stenosis, but
So would you try once again?
What happens?
I think Dr. Chakraborty's connectivity is issue.
I think so. Log out हो गए.
Mr. Agarwal,
Yeah,
we just talked with Dr. Chakraborty.
yeah. I think by this time, if Dr. Saibal or Dr. Ajay will just keep on some add-on. Dr. Mahajan is also there. You add on. Just I'm connecting.
Hi.
Questions are answered now.
I think he
Dr. Mahajan, how to deal with atrial fibrillation in this patient? He already told that during surgery, major operation, removal of the atrial appendage. That is one question, how to deal with atrial fibrillation in this patient. Dr. Ajay?
Managing atrial fibrillation, I think one is that we have to give anticoagulation, and since there's severe AS, it has to be warfarin. The second thing is that when this patient goes for surgery, should we also advise a maze procedure or not? I think Dr. Rabin is back. So that is still controversial. So I think we can just start with the tab.
So whenever, shall I start now? Because
Continue it.
So as I said that the aortic valve replacement mortality is significant, about 4%. And if you try to do with coronary artery bypass graft, the mortality goes up to 6.3 to 6.5 to 6.5%, which is significant today. And this is the data which has been published in 2004 as well as 2006, shows that many patients are actually not surgically treated because of a number of reasons. There are comorbidities, there are other conditions, the patients are not medically fit to undergo a prolonged anesthesia and ventilation because of lung reason, because of other additional comorbid condition. So the first one, the Partner 1 trial has come up. They've actually taken high surgical risk group of patients of severe symptomatic aortic stenosis. And with the SAPIEN valves, they found that in this group of patients, with high surgical risk patients, the transcatheter aortic valve replacement is possible. And the data shows that it is quite similar to the surgical aortic valve replacement as compared to the catheter based. At the same time, there is hospital stage minimum and a lot of advantages. In inoperable patients, again, the catheter based aortic valve replacement is certainly a considered option, because the catheter based surgical replacement is less invasive, lower risk of bleeding, and shorter length of stay and recovery, and similar rates of mortality and stroke in both high and intermediate surgical risk group of patients. There are, in low risk group of patients, there are concerns about paravalvular leaks or even pacemaker risk, because many of these patients may develop complete heart block. There could be a question about valve performance and longevity of these valves. There are anatomical considerations, especially in bicuspid aortic valve. And young patients, they likely to have multiple aortic valve replacements, so catheter-based valve may not be a considered option in this group of patients. But there are changes that new generation devices are safe and more effective. Both, there are two types of device. One is balloon expandable, another is self-expandable. In balloon expandable, the new generation balloon expandable valves are having a more safe, more effective, less pacemaker and less paravalvular leak. And there are this profile is small and sheet size is small. And progressively with the balloon expandable or self-expandable valve, the situation is also same. So based on this technology and understanding, people have started doing a study called LRP study. The objective was to assess the safety and feasibility of transcatheter aortic valve replacement in low surgical risk group of symptomatic severe aortic stenosis patient, where the surgical risk score or STS score is less than 3%. And then they found that in a month's time, the mortality was 0, which is amazing, which is really, it is incredible to have such kind of figure. So today, even in valve, particularly in TAVR, is an important therapy for patients at high and extreme risk of redo surgical aortic valve replacement. Those patients who had a aortic valve replaced earlier, second aortic valve replacement sort of entails a lot of risk. Therefore, in this group of patients, definitely transcatheter aortic valve replacement is an option, because it's an important therapy for patients at high and extreme risk of redo surgical aortic valve replacement. It is safe, effective in a select group of patients, although the durability is unknown, and new techniques evolved and developed to overcome potential drawbacks. Next frontiers of TAVR, we are thinking of whether to address asymptomatic patients. There's a trial called early TAVR, and also pure native aortic valve regurgitation we have to think about. But if you look at this slide, which is extremely important, published about 2 years ago, less than 2 years ago, and it has actually taken into partner 1A, the intermediate high risk group, partner 2A and SUTAVI trial, the intermediate risk group, and low risk like Notion at partner 3 trial. And when you collate all these trials together, they found that in terms of mortality in 2 years' time, there is significant, more than 12% reduction of mortality by transcatheter aortic valve replacement. Based on this information, it favors that TAVR may be safe in both high risk, intermediate risk, as well as perhaps in low risk group of patients based on these trials. And based on that, FDA expands the indication for several transcatheter heart valve patients in low risk for death as well as major complication associated with open heart surgery. So earlier, surgical aortic valve replacement is a gold standard, TAVR is an alternative. So from there is a change of technology. The valve size has gone down from 23 mm to something like 14, the delivery is 14 to 16 French, and the valve size is progressively coming down from say 29 millimeter to 20 millimeter. So there is a significant change of delivery sheet, valve size, both in balloon expandable as well as self-expandable valve. So by taking such technologies advantage, today perhaps the new generations are reaching to a situation where TAVR could be a gold standard as the first option of treatment of severe aortic stenosis like this, and surgery could be a traditional approach, maybe later on as an optional approach. So that is what is needed. So if you have a TAVI patient, doesn't require concomitant cardiac surgery, then no contraindication for TAVR, then go straight for TAVR. If the severe symptomatic aortic stenosis, the relative contraindication like poor transfemoral access, ages less than 65, bicuspid aortic valve, difficulty in coronary access, then you can think about it and discuss with the patient and consider as an alternative option TAVR. Of course, in those patients who require double valve surgery, like this case which was discussed, or patients with coronary artery disease and aortic stenosis, patients with other surgeries, then surgical valve replacement would be an option in this group of patients. But if you look at the transcatheter aortic valve replacement versus surgical valve replacement in balloon expandable valve in intermediate risk group of patients, a propensity score analysis has shown that all cause of death, cardiovascular death, neurological events, stroke, and all strokes are significantly reduced in a month's time and a year's time in transcatheter based valve replacement. Again, the transcatheter surgical aortic valve replacement in intermediate risk group and the TAVR, the significant difference between the TAVR and surgery in terms of mortality and disabling stroke. Therefore, in intermediate risk group of patients, it is advantage. Coming to balloon self-expandable group, again in intermediate risk group, it is an advantage. So in low risk group of patients with balloon expandable valve, data is so strong that probably even in low surgical risk group of patients, symptomatic aortic stenosis, this can be considered as you have seen in partner 3 trial. Partner 3 trial again has shown that the initial concern of paravalvular regurgitation in low risk group of surgical symptomatic aortic stenosis has been shown to be low as 0.8%. So significant paravalvular regurgitation, which is minuscule, which is important. So therefore, if you take transcatheter aortic replacement with balloon expandable valve in low risk group of patients, even the bleeding, the major vascular complication, even the acute kidney injury, or when pacemaker implantation is much less as compared to surgical group of patients. Similarly, in self-expanding group, a low-risk group of patients, all these data are quite favorable in terms of aortic valve replacement. It reminds us a great statement of Professor Eugene Braunwald, who says that the fact that two separate groups using two separate valves have come to a very similar conclusions, this not only doubles the acceptability, but it quadruples the acceptability. And if you look at the history, 1993 is the first description of valve sutured in stent. It was done in animal model. There's a problem because of obstruction of coronary ostium and other mechanical problems. The first human implantation was done by Professor Alain Crivier in April 16 in 2002 in France. Alain Crivier actually came to India many times and came to many hospitals, including our hospital, as well as many hospitals in India. So that was the first one, and that was 23 millimeter in diameter. Later on, again, there's a further change of the balloon expandable technology, and there's a continuous change from Crivier Edward to Edward Sapiens, and there's so much changes of this valve. If you look at the balloon self-expandable valve, again, there's a change from 25 French to 18 French and further down. That is what is the development of technology. In addition to the valve size, even the delivery system is also improved. And we have done some cases and we found that quite comfortable. We don't need any surgical sort of team assisting us. Actually, cardiologists, we are doing ourselves. So that is what exactly it is. So now we got further change of multi-level self-expanding nitinol frame, upper third, then middle third, and lower third. Did not get to those technologies. I'm going to finish in maybe another 5 minutes time. The very important role is imaging in TAVR. That is very important for the postgraduate student to recognize, because annular size is a very important information. So if you try to overestimate the annulus, then the risk of annulus rupture is there, valve dysfunction could be there. If you underestimate the annulus, the risk of embolization is there, and risk of aortic regurgitation or paravalvular leakage is there. And if you try to understand the annulus, annulus is not actually an annulus. Annulus is actually a crown with 3 branches. Can you see this is the crown, and there are 3 branches. So true annulus, the aortic annulus, and commissures, all these points need to be recognized. They are best understood and recognized by CT angiogram. That helps us a lot, because if this is the CT, you can see this crown is not circular. This is the crown, and there are 3 branches out of this crown, and there are variable orientation of these branches. Small diameter is often anteroposterior, large diameter is lateral. Variability between 2 diameters is extremely important. So these images are extremely helpful to plan the TAVR procedure. Echo is not isotropic, low resolution, then CT scan, lower resolution with depth, and larger diameters are often missed by conventional echocardiogram. CT scan, especially 3D and isotropic CT scan, is extremely helpful to understand the anatomy of aortic valve, aortic annulus, subaortic region, and supraortic region for the patients who is undergoing TAVR procedure. So CT scan, as I said, is also helpful. Also, the distance of the annulus from the bottom to the coronary ostium is extremely important, and certain distance has to be maintained before you contemplate to take this patient for TAVR. CT angiogram, as I said, is also important for arterial calcification, arterial tortuosity, and minimal luminal diameter for access of the delivery sheath, like the tortuous artery. Can you see that? It may be difficult, as a straightforward artery is extremely helpful. Like, and a lot of calcium is there. So these are the limitations one has to understand. Therefore, the CT, you can see calcification. The LVOT is extremely important. The LVOT is a little different. The CT LVOT is a little different from the 3D, from the echo LVOT. One has to understand that very clearly. Approach, there could be antegrade approach, there could be retrograde approach. Most of the time we do retrograde. From the femoral root, you take it across the aortic valve, and then you deploy the device there. There could be transapical approach, and there are various approaches, like from the other arteries, the brachial arteries, subclavian arteries, and transapical artery. Even people try to carotid, femoral. So many approaches are there. So those are the vascular access one has to be. Just this is for a completion of writing a kind of answer in your question sheet. But normally conventionally we do by transfemoral after proper CT evaluation. Approaches, as I said, these are the various approaches for us to understand. Some patient would require balloon aortic valve. We do not do balloon aortic valvotomy in all cases. In some cases, especially when there is a calcium, when there is proper deployment is difficult, then we think of expanding the valve with a balloon. Sometimes, if for balloon expandable valve, it is important to pre-dilate aortic valve by a balloon. So Edwards sapien implantation is a case where balloon dilatation can be done. This is such an example, Edwards sapien implantation. What are the complications? Complications, one is vascular complication like iliac rupture. There could be ventricular rupture. There could be acute valve dysfunction, coronary obstruction, multiple rapid pacing. This can cause hypotension after TAVR. One has to remember that. In addition to that, stroke, an important complication like atheroembolism, calcific embolism from the aortic valve, AR embolism, prolonged hypotension, even dissection of the aortic arch, especially when you go across the aortic arch. They don't go slowly. That movement should be quite fast. Quickly, you get into the aortic valve region. If you go slowly, then chances of stroke, chances of embolism, and chances of even hypertension, even dissection is possible. So one has to be quite clear about such technique. Embolic protection, people try to prevent stroke. Heart block, sometimes often we missed, especially incidents of complete. In the last patient we had, patient actually was patient had complete left bundle block. In the table, patient required temporary pacing. Later on, patient improved. But on third day, patient actually required a dual chamber pacemaker implantation. So, especially those patients with pre-existing bundle branch block, more so with left bundle branch block, chances of having complete heart block is very high after TAVR. One has to be aware of. Finally, today TAVR versus TAVR, it is a lower stroke, low mortality, less atrial fibrillation, quick recovery, better hemodynamics, and no scar, which is extremely important. These 5-6 points are extremely important for the candidates to remember and to write in the notes. Where does it go from here? We are now thinking expanding our new group of patients like bicuspid aortic valve and even aortic regurgitation, those kind of things. Severe aortic stenosis, bicuspid aortic valve. We need to understand bicuspid aortic valve. Various types are there: type 0, type 1, type 2, like no raphe, 1 raphe, 2 raphe. There are various classification of bicuspid aortic valve. This is important for us to recognize. It could be heavily calcified, and accordingly, one has to understand the bicommissional raphe type, bicommissional non-raphe type. I am not getting into all those details, but bicuspid aortic valve itself is an independent entity. So one has to understand that. So we are also thinking that in some patients there could be non-circular annulus. Annulus may not be circular. It could be non-circular. It could be heavily calcified. It could be presented at young age, severe symptomatic aortic stenosis. Up to 50% ascending aorta can have an aneurysm. So how to go about this? So these are the new areas where interventional community is thinking of TAVR in such complicated group of patients. And one is important is a straightforward case is tricuspid aortic valve, good artery, take it straight through and put it there. Aortic regurgitation, another thinking we are thinking of going ahead with TAVR. Pure native aortic valve regurgitation often present with dilated root, dilated ascending aorta, lack of valvular calcification. Probably this group can be taken up initially, but later on there is a trial going on in aortic regurgitation. As I said, expanding indication, we are progressively coming into valve-in-valve of TAVR, and that is one such example. As I said, bicuspid aortic valve, I discussed in detail about asymmetry, annulus size, varieties of types, aortic root pathology, and the aortic root is always abnormal in bicuspid aortic valve. So that is important. So bicuspid aortic valve I discussed. Now, the patients who are severe aortic stenosis but otherwise asymptomatic. Early TAVR trial is one such trial which is enrolling severe aortic stenosis in asymptomatic individual. We have to wait to get the result. TAVR unload will be compared to medical therapy in patients with moderate aortic stenosis, but patients with reduced ejection fraction having heart failure. Probably in moderate symptomatic aortic stenosis with left ventricular dysfunction, we can think of TAVR because at the moment it is contraindicated. It is contraindicated in patients who are very small size of aorta, and there is a other condition like heavily calcified aortic valve. Patient is of probably at the moment asymptomatic. We are not considering. Even in younger individual, we are not considering at the moment. Although we know that TAVR is less invasive, less peri-procedural mortality, better tolerability, a larger effective orifice area in TAVR. So, as I said, that we have to wait and see and expand this treatment for a wider group of patients to provide optimal care for the patient independent of individual physician bias. This is a slide which was presented in TVT 2016, and they say that in 2015 there could be 71,000. In 2025 it will cross 250,000 worldwide. That is a kind of projection of TAVR worldwide. Heart team is involved. Heart team has to sort of redesign themselves. Cardiologists a profound role, and we need to talk about it. So from the natural history of aortic stenosis, as I showed in the second slide, it is changing today by TAVR, and that is extremely important. In circulation, Dr. Brunwald wrote 1968 that this is the natural history of aortic stenosis, and today it is changing in 2021. So, but we have to also remember there are contraindications, like if there is severe calcified aortic valve, severe calcification of the axis, then, or maybe the areolar size is small, aortic root is abnormal, severe aneurysmal dilatation, there could be sort of a mild dissection. These are the absolute contraindication of doing TAVR. One has to be very clear about it. And if there are multiple valve intervention, valve plus the coronary artery bypass surgery, these are the situations when we do not consider TAVR in this group of patients. However, but progressively it appears that TAVR is posing a complete solution. Symptomatic patients with severe aortic stenosis more than 70 years, yes. Severe aortic stenosis is intermediate surgical risk, probably yes. Severe aortic stenosis is mild surgical risk, probably yes, because now we are getting data. In distorted anatomy like bicuspid aortic valve is a new expanded indication. Valve in valve, we are thinking even in mitral valve by reverse crimp technique. Remember the reverse crimping of the valve can be done over the delivery sheath and can be deployed across the mitral valve. So that is another way of using the valve, TAVR valve in mitral position. Valve in valve is severe reverse technique in mitral region. Asymptomatic severe aortic stenosis, you have to wait to get the result. Aortic regurgitation, again, you have to wait to get the data from the trial going on. Till that time, but SAVR will not go. Surgical aortic replacement will continue. I'm sure there will be new areas of indications of surgical aortic valve replacement. There are patients, those patients probably would not be qualified for transaortic valve replacement. For them, surgical aortic valve replacement has to be considered. So surgeons will not starve. They will also continue to grow, continue to thrive. At the same time, the TAVR technology will improve, and interventional cardiologists also have a very special training and special skill to do such procedure. Thank you very much for your attention. Journey has just begun, and we have to continue with this journey. Thank you very much.
Thank you, Professor Chakraborty, for your excellent lecture in very short time of the huge topics. I think all DM and DNB PGT will be benefited by this lecture. Thanks all the panelists for their fantastic clinical discussion. Thanks Vidyut for good presentation. I think already it's past 9 o'clock, so I hand over to Mr. Kanu Agarwal for giving us this platform for discussion, very good discussion for the DM and DNB PGTs.
Yes, sir.
Dr. Agarwal, Mr. Agarwal, please.
I think it's truly honored having such a wonderful program for all the DMPG students. They are highly appreciated this program. Around 600 DMPG participated. And on behalf of Ajanta, I'm taking this privilege to convey heartfelt thanks to Dr. Rabin Chakraborty, wonderful session, Dr. Saibal Mukherjee, as well as Dr. Bahl sir, Dr. Mahajan sir, as well as Dr. Mandal. And thanks, Dr. Vidyut, for a nice presentation. I think very important, sir, you have shared a lot of important critical insight about the valvular heart disease and the management. I think that's a wonderful, as all take-home pearls for all the DMPG. So on behalf of, once again, I like to thanks to all our participants, audience. And this kind of scientific program will also continue in future as well. So thanks for your support and encouragement. Yes, sir, Dr. Mandal. Yeah, please.
Next series, that 3, in fact, eminent cardiologists will be there. That hemodynamics by Professor Ranjan Sethi, X-rays by Professor Mahajan, and ECG and EP tracing by Professor Rabin Chakraborty.
Yes.
Yeah, and I think, Saibal, what do you think? I think we should also have some session on because this point, I think last time we discussed about how the same valvular damage can continue to become worse because of the hemodynamics. I think boys should understand it. I think we should have a special classes on that. You need not have the disease coming back. It is the same disease which progressively get worse. So the afterload, preload concept has to be taught. That is what I think. And imaging has to be given some special attention. A lot of images are coming up. I don't know, Ajay Mahajan, what do you think? Ajay Mahajan for the PG?
Yes, sir. Absolutely. Basically, we have to inculcate those concept of imaging, particularly when they see the patient. They should foresee what will be the natural history in this particular patient, and what will be the ideal imaging, and then they will decide regarding the therapy on that particular patient.
In fact, in the case, when Saibal was discussing so good questions on echocardiogram, so many questions about the color mapping, before that how to do the 2D, then the non-cooptation. I was just thinking, these boys, after he passes, he will never go to echo lab. He will be in the cath lab doing angioplasty. That is what is happening to this new generation of DM. They are not taking echo and imaging as a kind of a procedure or career, which is very unfortunate for whatever may be the reason. But echo and imaging, even CT imaging, MRI imaging, a lot of radiologists that they are coming in. Why not DM cardiologists are going? I don't understand. And you people are in teaching profession, Saibal, Dr. Mandal, Ajay Mahajan, Ajay Bahl. I could also see your input would be extremely important.
But I think valvular heart disease, everybody has to see in its clinics. You cannot escape valvular heart disease. You cannot escape rheumatic heart disease. Maybe you are not doing actively, but diagnosis is the crux. You have to, if you have to send the patients the surgery, you have to give this information to him, which is very much a job of a cardiologist. And I think angioplasty is not only, that is the biggest menace, I think.
Yes, that
cardiology is not only angioplasty. Okay. So cardiology, the structural heart disease has now got revived to a great extent. As sir has very beautifully shown the way we have succeeded with TAVR. Days are not far up and we will have a transcutaneous mitral valve also. The 10-9 valve and all things are coming up, and it is the structural heart disease which will take over in the next decade. I mean, this decade and next decade will belong to structural heart disease.
Correct.
And we should.
What about TAVR in rheumatic heart disease, Rabin?
Not yet. I don't think there several any data on rheumatic. I don't think so. It's only on degenerative aortic heart disease.
Yes, rheumatic heart disease. They have tried. We have some data. But
the main important thing is that longevity is not there in rheumatic heart disease. So we are not getting the patients who are elderly more than 70, or we might be getting some patients. There might be some rheumatic involvement, and then there is a double impaction with a degeneration.
But I think one more reason is that if you look at the data literature, isolated aortic stenosis is very rare in severe rheumatic heart disease.
Yes.
Always in combination. Either aortic stenosis, aortic with mild mitral valve disease. So these are the relative contraindications for catheter-based valve implantation at the moment. Ajay Bahl can educate on us.
Yeah, and I think that is a very relevant point. We must motivate more cardiologists to get into imaging. At least a few cardiologists must get into imaging.
Yes.
At this time, it is extremely important, especially MRI is becoming increasingly important, and MRI and CT should be by cardiologists rather than radiologists.
Agreed, absolutely. I think you people please make a mandate, and we can appeal to any.
Like for yes, sir. It's like for TAVR, CT angios and most of us now, the cardiologists are getting more and more involved, because for planning you need to understand the anatomy, and now the cardiologists are slowly getting into it along with the radiologists. But it is a must, I think. Yes.
Especially understand the LVOT. A lot of things are there. That LVOT, even the cusp to coronary artery distance, even the aortic the sinus, the crown. These are very new sort of understanding, recognition of anatomy.
Yes. Not only TAVR, all group of disease, you see big cardiomyopathy, big congenital, all group of disease, MRI, CT angio has taken active part. In fact, cardiologists should have to go to the
MRI now, because for volumes and sizes, and I think MRI is much more sensitive and than echocardiography. Yes,
we don't have any fellowship like
myocardial tissue typing, then for preventing arrhythmias, then preventing left ventricular dysfunction, predicting left ventricular dysfunction. The MRI is one of the most important investigations.
Yes, absolutely. You're so right. So maybe professors like yourself, you can probably be proactive in motivating our universities and national board. So that would be very helpful. Then the boys will take it a career, and professionally also, because I think it is less paying. So that will be the reason.
Okay. Thank you once again, sir. Dr. Wonderful program. Thanks all participants. Please stay safe and protected. Good night, sir. Thank you, sir.
Thank you.
Thanks.
Thank you.
Nice.